To quote Pocahontas, these white men are dangerous.
You're not wrong.
Like,
poor Natalie.
I know.
You know, for a while, Natalie Holloway's mom dated JonBenét's dad.
That's too much. I mean, I get it. They're trauma bonding, but also like
They didn't end up together though.
no, because she probably found out. She knows it's the dad. She knows something we don't know.
No. Do you think we'll ever know who killed JonBenet?
No,
I know.
I don't.
I'm sad about it.
I wish we did. Maybe that'll be like left on his like.
Why
death
are we
note.
not using Ancestry DNA?
For what?
The DNA in the JonBenet case.
Because they don't want us to.
I know.
Hey everyone, and welcome to this week's episode of your weekly therapy podcast. I'm at Tell Williams, or Mr. Williams, if you know me online. I'm a social worker, teacher, and therapist, and over here we have...
I'm Anne Marie DiPietro, and I'm still a nurse practitioner.
And still here.
I'm here.
We were just talking about like the kind of week we had. I don't know if you've been experiencing this too. I have never had so many clients talk to me about politics and like their fear of the world right now.
I know.
And it's like I am like going through and trying to figure out like what can I say to help like relieve some of that anxiety. So I've literally been searching like anywhere I can online of like positive news or like encouraging news and stuff because it's bad out there.
It is.
Oh my gosh.
It is. There's like this conversation I have with patients when I ask about their anxiety where we have a portion where they're like, you know, the normal anxiety about the world right now.
Yep.
And then we're like, okay,
Yeah.
Validate, acknowledge, move on. Like, other than that, it's fine.
It's like I had like at least 2 or 3 clients this week be like, I'm like, how's everything going? How's everything going okay? And they're like, I'm actually doing really well. Besides like, you know, the impending doom of the world and then like actually go into detail about how like dramatically it's affected them. Like I don't think I've ever felt so personally attacked by an administration. It's fine.
No.
It's fine.
I've never had so many conversations about like what countries we should move to with clients.
No, it like several clients have been like, yeah, I've been looking at this or like, you know, Amsterdam would be bad or, you know, it's not even in Canada anymore. Canada's too close.
Oh, no.
They're like,
No,
I got to go
Canada.
somewhere where there's an ocean between. It's wild.
I'm down for Aruba.
I don't know what that, like, I mean, I know what Aruba is, but I don't like know Aruba that way. Is it fun?
Yeah.
It's warm.
Yeah, it's warm. They like the gays there.
Oh, then yeah, let's go. How's their mental health services?
I mean, they could probably use us there.
Nice. We can
Probably
rebuild.
fine.
We can build back better.
We can build it back. Yeah. They're like one of the only Caribbean islands where it's like safe to be gay.
Okay,
They've had like
well-
a pride parade for like a long time.
We should go there.
Because they're owned by, oh my God, I'm so bad at geography, but they're owned by a nation that's pretty progressive.
But I mean, they're owned though, so.
The Netherlands.
Okay, well, we like the
Yeah.
Netherlands actually.
Yeah, it's a country within the Netherlands.
Okay,
Yeah.
well, okay, let's go.
Yeah.
That's where we'll
And
run
if
to.
you buy a piece of property in Aruba, it's a lot easier to become a citizen.
Would we be Arubian?
Oh, I don't think so. I think what are you considered if you're part of the Netherlands?
No, I was gonna say Neanderthal, but that's not. Oh my God!
Definitely not. No.
Oh no! It's a
Oh, Dutch.
Oh my God! What is wrong with us?
Okay, so Holland is part of the Netherlands, and apparently people sometimes wrongly refer to the whole thing as Holland, but Holland is just a country of the Netherlands.
Okay, well, we're learning.
Oh yeah, remember Natalie Holloway?
Yeah.
Or do you really not remember? Yes, in Aruba.
And her roommate. And everyone thought her roommate.
And it was the Dutch guy. No.
was
Now you're
that?
getting Rome confused.
Oh.
Amanda Knox.
Oh, Amanda Knox. Okay.
I know.
Yeah.
Natalie Holloway was the one that was on like her high school trip and she
Yep.
went missing in
Yep.
Aruba. And then it was that Dutch guy and like they never like caught him for it, but then he like killed someone else.
And they
now
caught him
he's
for
in
that.
jail anyway.
Oh,
Yeah.
well, justice eventually was served. I don't know.
Yeah.
I mean, listen.
I mean, hopefully we won't get in with those Dutch when we move there, but
to quote Pocahontas, these white men are dangerous.
You're not wrong.
Like,
Poor Natalie.
I know.
You know, for a while, Natalie Holloway's mom dated JonBenét's dad.
That's too much. I mean, I get it. They're trauma bonding, but also like
They didn't end up together, though.
no, because she probably found out. She knows it's the dad. She knows something we don't know.
No. Do you think we'll ever know who killed JonBenet?
No,
I know.
I don't.
I'm sad about it.
I wish we did. Maybe that'll be like left on his like.
Why
death
are we
note.
not using Ancestry DNA?
For what?
The DNA in the JonBenet case.
Because they don't want us to.
I know. Why not? We should talk about that conspiracy.
We could have an entire episode on conspiracy theories. In fact, we should do one because I choose to believe that J.D. Vance killed the Pope. As gay people, we get to choose our conspiracy theories, and that's when I believe.
I mean, I believe the Pope was getting too progressive.
He was. And here's the thing. Do I actually think J.D. Vance could have done that? No. Whatever he wants to do, he never can do, right? He fucks everything up. So unless he was like, I really want the Pope to like me, then yeah, I guess he intentionally killed the Pope. But if he set out to do it, there's no way. I actually got another violation on my TikTok for this.
No, for your RFK stuff?
No, actually, I did make a video. I'll have to show you guys after this of RFK, and I showed it to Jason yesterday, and he was like, that's really funny. You might get canceled. But it's really funny because I'm making fun of RFK. No, I said that I think that J.D. Vance, and I literally said, J.D. ended the Pope. That's all I said. And it flagged me and gave me a second violation now. So it's like, if you get 3 more violations, we're taking your account away. And I'm like, baby, you're probably taking the account away because I don't think I can control myself right now.
Oh my God. What happens if they take your account away?
I don't know. I guess like it's gone. Like
you're like, bye, back to regular life.
I mean, yeah. I mean, it's not something that I really like. Oh my God, what happens? I don't know. I just go to Instagram. They've never flagged me there.
Well, once RFK comes up with the cure for autism, then you'll be in treatment. So.
Right. Can you imagine? So we talked about the ADHD farms before, like that he wants to send people to. Can you imagine if he sent me to one, like if there's like one for like autism that he wanted me to do?
Autism rehabilitation camp.
Baby, like I'm gonna need you to be so specific. You can't. I'm gonna take everything literal. He'll be like, "Can you take the cows out?" I'm like, "Bang, bang, bang." He's like, "No, I meant like on a walk or something," or like. He can't be doing that to me.
I just imagine he's going to have everyone like hooked up to IVs, giving them all sorts of like antidotes in his opinion, since he thinks we're going to find some
cure
root
for
cause to neurodiversity by September.
Yeah, for a disorder, not a disease. He's so dumb. Like this guy.
I feel like this guy needs to go literally like look at the autism spectrum, like go to a like residential facility for individuals with autism and intellectual disabilities, go view that, and then like go talk to Tell over here. Like we're not finding anything by September, sir.
Like I just need him to go like eat glass and just live out the rest of his day on a farm if he wants, But Cheryl Hines, his wife, his actor wife, she got to get it together, sister. You got to divorce the man, okay? He put a whale head on the top of his goddamn car and drove like that for 5 hours with his kids in it. Like, this man is off his rocker.
It's like laughable to me that people even take it seriously. Like I saw some article, I forget what autism organization it was, but like the woman was talking about how like his statements made her feel hopeful, and I was like,
oh,
his
honey.
statements made me feel like my career for the last 15 years, like I must have been delusional, like hallucinating everything I've known.
I think that like what he and this administration is really good at is taking people who are just feeling like existential dread in life in general and like figuring out ways to for them to feel like they're being empathized with. But it's like, baby, that should make you feel hopeful. That's eugenics he's talking about. That ain't a good thing, sister girlfriend.
No.
Like, what the fuck?
No.
This man, I cannot with this dude. Like,
it has gone all downhill since the day he said that SSRIs are harder to get off of than heroin.
My God. I was like, baby. Or like his entire thing right now about like ADHD being what is it? From being like harmed, like you were hurt. It's a
trauma.
Yeah, like it's something that like you experienced like
Is that what he
an
said?
accident or something. Yeah, like people with ADHD and this and this. It's like they were like hurt or whatever. I can't remember the word that he used, and that's why it's from a injury.
Oh.
He says that like ADHD, autism, these things be caused from injuries. I'm like, wait, what?
I can't.
It's too much. But initially, like a while back, we were talking about how he wants people that are on like stimulants to no longer like can't use them anymore, got to get rid of them, and then send people to the ADHD farm.
Yes.
And then that got us talking about kind of today's thing on medication and prescription farms. Is that what it's called?
I named them prescription farms.
I kind of love that name though.
Yeah.
So this is something that like I know some about, but I feel like I'm going to be here with the listeners and you're going to educate us and I'm going to ask 1,000 million questions about it. So what is your self-titled, what is a prescription farm?
Okay. So here's my theory of what I think happened. Over the pandemic, right? So my practice has been open for 10 years in December. I like never had an issue getting referrals, right? Ever. So then the pandemic starts. I'm still getting consistent referrals, whatever. And then they like start slowing down, which is like really bizarre around like year like 8, 9, 10 of a business, you know? And then I'm thinking to myself, like, what is going on? But then I'm on social media and I'm seeing like all these ads for these like online places that you can get ADHD medication, anxiety medicine, depression medicine, whatever. And so two things happened. So first, then I started to get some patients that said that they were going to some of these online places, like Cerebral and Done are the two that I have like the most information on. And then all of a sudden they like stopped being able to get their medicine from them. So I did a deep dive into this and it's pretty fucked.
Yeah. I remember seeing some of these too, but it started off as like depression medication, which I'm like, oh, okay, like that's not easy to screen for. But then when it started talking about like stimulants, I'm like, that's a really difficult thing, like to like just.
Right. Well, I actually think Cerebral and Done both started with ADHD. I think some of the other companies started like with depression and anxiety because here's what happened. So there's a thing called the Ryan-Haidt Act, which is part of the Controlled Substances Act, and it said that prior to the pandemic, it said you had to assess someone in person prior to issuing a controlled substance script. So that really prevented any of these like online ADHD things because you couldn't get controlled substances anyway. So the Ryan-Haidt Act was suspended during the pandemic, so it opened the door for controlled substances to be prescribed without an in-person evaluation. So that's where this all started.
Yeah. Which was like to meet needs of like telehealth, right? So so if you can't go see your PCP because the world's ending because it's COVID, you could see them telehealth. It wasn't to really make ways for like better help, but for mental health meds.
Right. Exactly. Yeah. And for a lot of things too, like for Suboxone, people needed access to their Suboxone during the pandemic. So that's a controlled substance. And that was even more highly regulated and that's been relaxed since. But anyway, so Cerebral was the first one, at least that reached some settlement with the DOJ and the DEA. But listen to this. So they had internal metrics that 95% of initial evaluations were supposed to result in a controlled substance prescription.
Oh. And here
and supervisors got bonuses based on how close they got to the metrics.
Isn't that illegal?
Yes.
Because you talked to me about like even like drug rep like lunches and stuff, and there's so many things you can and can't do.
Yeah. Like I'm a speaker for 2 different drugs, and they're not even allowed to look at how, when, if I prescribe. Like there are drugs that I could speak for that I never prescribe ever. And like no one involved in selecting me, having me speak, whatever, can ever know what I prescribe or when, because you literally can't even give a pen with a drug name on it to a prescriber. They call it anti-kickback laws.
Yeah. And like, which I'm glad we have, right? So that you don't have what's happening here where there's and we're not like sticklers on like if someone needs stimulant, give them a fucking stimulant. But like that 95% of people, like I know there got to be a lot of people with bipolar disorder that did not, you know what I mean?
Right. So here's my So there's so many problems with this. First of all, their rejection rate of clinicians that applied for jobs with them was 1%.
So they said, let them all in.
Oh, yeah. Right. So then they're giving all of these people controlled substances, right? They screw it up for everyone else. Done, that one's even worse because Cerebral, they reached a non-criminal settlement with Done, the chief operating officer, the clinical president, and the CEO both were arrested.
Wow.
For 40 million pills of Adderall and other stimulants being given without legitimate medical purposes, deceptive marketing, inadequate medical evaluations. The evaluations were under 30 minutes. Providers were compensated based on the number of prescriptions they issued. They were discouraged from doing thorough evaluations and follow-ups. Oh, and they billed Medicare and Medicaid and private insurers. So then they got dinged on $14 million of false claims.
My mouth is like literally just hung open. I had no idea. I knew that because we talked around the time that this was happening, but I didn't know it was like this. I just thought it was like, oh, people can't go there because this was this what caused the shortage?
Well, I mean, they say that it contributed to it. I have all sorts of conspiracy theories about the shortage, too, because the shortage is still ongoing. And initially it was because of DEA limitations on production. And then it was because of certain ingredients that weren't available. And maybe it's, who knows? I don't know. Maybe during the conspiracy episode, we can talk about the stimulant shortage because it's still a thing. Like, I think we're going on 4 years maybe of the shortage. But here's my biggest problem with Cerebral and Done, because I feel like what people have taken from this stuff is ADHD is bad. We diagnosed all these people with ADHD and they didn't need treatment and blah, 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 blah. But now, do you know, with these companies, a lot of them, it's more than just Cerebral and Done. So what they did in response, because a lot of major pharmacy chains stopped filling scripts from these companies even before they got shut down. So these companies still exist, but they don't prescribe stimulants. So here's my problem. These companies still exist. They'll treat depression, anxiety, ADHD with non-stimulants. And they don't use any controlled substances at all. Okay. So now we're talking about these companies still taking on patients with the same level of assessment because I've actually done some, undercover intel and interviewed to be a provider with one of these companies. And they expect you to see a patient in 30 minutes or less, and then you don't see them for 3 months, but you respond to their messages in between. And then you're compensated. They want you to see 6 people an hour, something ridiculous.
Oh, for the med checks.
Yeah.
Med checks.
For checks. Yeah. So regardless, though, if you go to one of these companies and get a quote unquote assessment, right, is it not in their best interest to diagnose you and treat you for something that doesn't require a controlled substance?
Yeah.
Because otherwise, they're referring you out. So you, as a clinician that makes money only on the patients that see you, are you going to be like, you know what? I think you should go somewhere else and see another provider who's able to diagnose you with ADHD and give you an evidence-based treatment that's shown to be more efficacious than non-stimulants.
Yeah.
So I'm not saying that there's not a place for non-stimulant medications. There 1,000% is, but it's not first line.
Well, not to mention, again, they just went from overprescribing one thing and keeping patients to now potentially underdiagnosing or under-medicating so they could, again, keep. So either way, to me, it's super unethical.
Right. And we know that with ADHD, especially in adults, there's a lot of depression, there's a lot of anxiety, there's overlap with bipolar disorder, there's overlap with trauma, there's overlap with personality disorders. First of all, it's hard for me to even separate all that out in 2 hours a lot of times. I was almost at 2 hours of an evaluation this week, and I said to the person, here's what I think is going on right now, but these are all the factors that I think we still have to address. So let's make our plan B A, B, C, D, and we need to revisit this because there's so much happening here. If I would have seen that person in under 30 minutes, like, I don't know, I probably would have been like, I guess you're depressed. Like,
Right.
like, what do you even say?
There's not enough surveys in the world that they could take prior for you. And like, when are you going to check those out? Like, because you have 30 minutes and then the next. When I told you I was working at that community health center before we started working together, like, they wanted the therapist to see the clients no less than 3 times before they could book with the psychiatrist. The psychiatrist had to see them within, I think their evaluations were 30 minutes too, or maybe an hour. But then we had to be a part of that process of like, oh, like, what do you think it is? Which is great. Like, I think that, like, multidiscipline in diagnosis is fantastic. But our initials, I think I've told you this before, we had an hour when we got the initial phone call from a client, and within 45 minutes we had to have an idea of what their diagnosis was, and we had to like have a goals plan set up for them already in 45 minutes. That's like if you had to fully diagnose and prescribe, that's the thing, is that you're not just diagnosing, you're diagnosing in 30 minutes and prescribing them something in that time. That's so unethical.
Yeah, well, it was maybe like my 3rd job out of grad school, probably around like 2013 maybe. I was working for a community mental health center in Coatesville, so there was a lot of need there. And they had me doing 6 med checks an hour. So they hired a quote unquote what did they call it? Psychiatric assistant that was supposed to see them for 10 minutes to give me information so that I, in the next 10 minutes, could see them. And I used to work 12-hour days. So ultimately, I said to the chief clinical officer, if you were the 70th family I saw that day, like, would you want me prescribing medicine to your kid? Like, I cannot do this. I'm not going to do this. Because the second I started thinking things in my head, like, oh, it would be easier to not change the medicine because I really don't have time in this appointment. I was like, nope, done. I'm not doing
100%. No, absolutely. I mean, there are times that I literally have been like, I need to start, like, I can see this client, this client, this client in a row, but like I know this last one can be like difficult, so then I need a break in between because like maybe I'm like getting, my own trauma from, or thinking like when you're that rapidly seeing people, and again, like you're doing meds, which is a whole different thing, right? If I like trip up and say the wrong thing, or I'm like, oh my God, can you go back? Sorry, I'm so tired. I was zoning out. Like, that's so unfair to you. It's so much different in an hour conversation I have with someone than you having 10 minutes, 6 people in an hour. That's too much. Oh my God.
So when you posted those clips last week, which one? On the binge eating, when you were talking, the clip when you were talking about the olanzapine when you were misdiagnosed with bipolar disorder, in your comments, there were like hundreds of people talking about how they were put on certain medications and then basically like gaslit by their providers to say like, the medicine isn't what's making you gain weight. Like, you're not gaining weight from this. And people were saying like, I was put on this and then I was like super sedated and my provider said it wasn't from that. And I gained 82 pounds from this in like 6 months. And then the thing that upsets me the most, and I think that's what ties into this whole like prescription farm thing, because we don't have like the time or the relationships aren't cultivated. The thing that bothers me the most is then patients are made to feel like I need to choose my mental health or my physical health, comfort, and well-being.
Yeah.
Like, literally, people wrote that in your comments.
Right. Well, I mean, I talked about it. If you didn't listen last week, I said that I literally had a doctor that, what's it called that I was on?
Olanzapine.
I know that you know the name, but I was like, it's the one that was doing this. I gained like, I think it ultimately was like 50 pounds in like a month and a half or 2 months. And I remember going to the doctor, and I had even said last week, like, I was like, hey, like, I'm miserable. I'm gaining weight. And for a while, he did gaslight me. I was like, well, what are you eating? And let's look at your diet and stuff like that. And yeah, I was binge eating, and I had binge ate before, but like maybe nothing else changed my life other than this medicine. And I remember at one point he had said to me like, okay, well, like you like this weight it's there, and we can exercise and eat better, but like, would you rather that or like, die because, of your mental health? And I'm like, that is so fucked. You would tell a client that, like,
right.
And I will always say it was very physical. Like I literally was getting like cellulitis because like my like thighs were rubbing against each other and it hurt so bad. But like also there was some vanity in that too of like
Right.
I didn't feel like I didn't like the way I looked.
Mm-hmm.
And when we completely discredit that, just like, well, sorry, it's like no,
Right.
then I'm not gonna take the meds. Like, and
Right.
eventually that's exactly what I did. I was like, this I would rather like be depressed than
Mm-hmm.
be depressed over my mental health because right now I'm depressed anyways because I can't like walk up a flight of stairs without
Right.
dry heaving.
Right. There's a couple things. So I actually looked up olanzapine's data because I
Mhm.
was like, there were a lot of people in your comments that mentioned olanzapine, then there were a bunch of other meds that got consistently mentioned. But when I say like, so weight and vanity is one thing. Weight and metabolic syndrome is a completely different thing. So the FDA mandates that any antipsychotic medication, olanzapine being one of them, has a warning for metabolic syndrome. Metabolic syndrome is a real thing. When you go on a medication, you gain rapid amounts of weight. Sometimes it's not even just the weight. Your cholesterol goes
Mine
up,
was
your
through the
triglycerides
roof.
go up, your blood sugar goes up,
Yep.
and you're creating this metabolic syndrome that has now put someone at high risk for type 2 diabetes.
Yeah.
Period. The end. Research, like that's based in research. There's no fat phobia here.
No.
That's solid
Right.
research. Okay, so when you prescribe olanzapine, as a prescriber, you are taking on the liability of whatever that causes that patient. So of course, providers who maybe don't, I don't know, care enough are going to be like, no, it's not the medication. But I mean, anyone who says that with olanzapine is Delulu,
Just
really.
look. I mean, just look at their chart from like before they took it to
Well,
now.
or look at long-term studies, because in long-term studies, after 48 weeks of exposure, which is almost a year, the mean weight gain was 12.3 pounds. That means more than 50% of people gained more than 12.3 pounds. The percentage of patients who gained at least 7% of their body weight, like, so if someone weighed 100 pounds, that's gaining more than 7 pounds. So 64%.
Yeah.
64% of people gained more than 7%
Right.
of their body
More.
weight.
Yeah.
Now, what I'll say about olanzapine is there's a subset of the population that does not gain weight with it, and they
Yeah.
think that there is a gene that predicts whether you are one of the people that's susceptible to gain weight with olanzapine, which most people are, or you're one of those people that doesn't. And for the people that don't gain weight from it, it's a miracle drug for them. Great.
Which is
But-
fantastic. You're the X-Men of
Exactly.
drugs.
Right. But like our job as a prescriber is to weigh the risk versus benefit of
Yeah.
everything that
Yeah.
we do.
Yeah.
And I think that it's so I was actually like humbled a little bit the past 2 weeks because I was in this like mindset after reading your comments of like I always validate my patients and I listen to everything they say and I meet them where they're at and whatever. And I had this patient and I asked her about like mentioning it, but and she said it was okay, but she has a ton of medication anxiety, right?
Yeah.
And so I had put her on a medication, super tiny, like baby low dose of a medication, 3 times a day. And she wanted to come off it because she thought that she had a side effect from it. And I told her how I wanted her to come off of it. And she was like, no, I can't do that. I looked online and all these people said that you have this horrible effect when you come off of it. And I'm trying to educate her, like, that's not the case. Like, I wouldn't tell you if it wasn't, you know, whatever. And I'm going through it and I'm like finding myself getting frustrated. And then I was like, okay, just do like cut it in half then and we'll meet again next week. And I was like, ugh, you know, and then the next week I was like trying to get myself in the right headspace to like have this meeting. And then I was like, you know what? It's my job to help this woman feel better. And I'm not going to help her feel better by making her feel crappy about her not listening to me and how I want her to get off the medicine.
Right.
So I met with her and I was like, listen, let's just try to make a goal that you get off this medicine within the next 2 weeks. And we'll try to have you decrease like tiny little bits over the next 3 to 4 days. And then we'll just have like small milestones. And then after that, we can start a new medicine once you get off of it. And she's like, I really just can't start something new until I'm off this and whatever. And I was like, I can't push it.
Yeah.
I was like, I just have to get her comfortable enough to put one foot in front of the other,
Yeah.
right? And I got to that point and I just kind of said that to her. I was like, listen, you need to do what you're comfortable with. It might not be exactly what medically I would recommend, but like, let's do this. Well, I'll
Yeah.
meet you where you're at. And she was like, oh, Emery, thank you so much for listening to me. I feel like really heard by you. And that like put me in check. So I was like, oh my God.
Yeah.
Like I almost just fell into it
Yeah.
myself. You know what I
Yeah.
mean?
Well, it's that fatigue. Like, and for someone who like you spend time with your clients that we share, clients that you will like have come to me for. That's like the one thing is they're like, I'm like, okay, I'm seeing Anne Marie before you for a med check. I'm like, okay, so like how long should I expect? They're like, oh, like usually it's like 30 minutes. Like that's like a fantastic med check. You know what I mean? Like that's like wholly like listening. And so like I think that when you're feeling fatigued and you have 30 minutes, if not, sometimes you go like over even with clients, stuff like that. I can't imagine what someone who's seen 6 clients for 10 minutes at a time is feeling, right? If you're feeling that fatigue but you're able to check yourself and listen to them and read that, you can't do that in 10 minutes. You know what I mean? Like,
yeah. And I mean, don't get me wrong. Like, I have clients that I've been seeing for like almost a decade, and we could do their med check in 10 minutes,
100%, right?
And then chit chat the rest of the time. But the reality is, like, both of us worked pretty hard to get them to the point where they can have a 10-minute med check.
100%.
You know what I mean?
And they have the ability to call and say, this happened, or I've suffered a loss, and I need more than that. And you would set up more than 10 minutes.
Right.
These places, I don't even think they probably have the option to do that.
Right. And then the question too is the provider you're seeing willing to hear you out?
Yeah.
Because a lot of the comments about weight in your comments were about aripiprazole, which the brand name's Abilify, and how providers were telling these people like you didn't gain weight from the Abilify, which is really a misnomer because Abilify came out probably when I maybe like a year before I graduated from grad school, so probably around like 2010 maybe. And it was like touted as this like low weight gain medication because, well, yeah, at the time we were comparing it to olanzapine. So like, sure, it had less weight gain. You know what I mean? But now compared to newer meds that we have, it's not,
right.
You know, the weight gain profile, while better than olanzapine, is not great.
Right, yeah.
And especially in like the child and adolescent trials. Anyway, what you can do if you're interested and don't want to be gaslit by your provider, if you search for the FDA package insert on Google and then you put like search for weight, it'll show you like the table of weight data, and every drug will have like what percentage of people gained more. It's usually 7%, more than 7% of their body weight on it. And it'll tell you changes in cholesterol, triglycerides, blood sugar, prolactin. These are all like components of metabolic syndrome. So you can educate yourself and then bring it to your provider and be like, hey, look at this.
Yeah.
But then also, let's just like put this out there that some medications that have a low potential for weight gain, that doesn't mean people aren't going to gain weight on them.
Yeah.
That doesn't mean that anyone is not going to have any side effect from whatever drug.
Right.
So I think that it's our responsibility when we prescribe medication to say to our patients, like, if you feel something that you didn't feel before, let's talk about it.
100%.
Because, I mean, sure, it might be because, like, you switched your laundry detergent 2 days after you started the medication, and now you have, like, a rash on your body. But, like, let's talk about it before I'm like, no, that medication doesn't cause a rash, you know?
Well, and this is, like, one of those things, too, because if you're wondering why we're not harping, but, like, focusing so much on the weight gains, because that's, like, what people were commenting so worried about. And I think that says a lot, is that, like, that is something that people are really fearful of society and all that, but like, you know, of beauty or body standards. But you said something that like kind of hit the nail on the head, and something that like I had experienced again, like before the weight gain, I think it was 19 when it started. No, I might have been a little older. I can't remember. Before the weight like really went on, because I did like a 2-week check, the cholesterol was out of control. And so for me, I think a huge thing is like even when I lost some of that weight, it took like 2 years to lose the weight. It took a month to get it, 2 years to lose the weight then, and 10 years to get down to like a healthy weight and blood labs. Like I just got to that like 2 years ago. My cholesterol was bad until I was like 26, 27, I think. I mean, for years it was bad, almost 10 years. Like that medicine and being on for so long and then being put on lithium and stuff like that, like it destroyed my physical health, And yeah, I feel like that's something that like the weight, in some ways, thank God that the weight did happen because I think that they would have just brushed the blood labs, just brushed them. Oh, it's not that big of a deal. It's not that big a deal. When the cholesterol got so bad, he's like, you have a cholesterol of like an 85-year-old man. I'm like, well, I'm not, babes. I'm 20.
Yeah.
Like this is very unsafe.
Yeah.
Yeah.
And I mean, I think, like I said, there's multiple aspects to weight gain.
Yeah.
There's the patient aspect, and then there's our responsibility as a prescriber to not make people's health worse aspect.
Right.
Like, and it's recommended. And in Pennsylvania, by Medicaid, if an individual's under 18, you're required to do metabolic monitoring at like 1 month, 3 months, 6 months, like ongoing, because we know that this is an effect of a lot of these medications. So from a health perspective, we don't want to cause metabolic syndrome. And I don't necessarily mean to equate weight with metabolic syndrome. It just so happens that often is the case. But also then there's this like large percentage of patients who are going to be non-compliant with medication if they're gaining weight from it. So what is the point of me continually saying to a patient, no, it's not the medicine making you gain weight. No, the medicine doesn't make you gain weight. Meanwhile, they're taking it like half the time, because and then they're afraid to come to me to report a side effect because I've just gaslit them into believing that it's not actually a side effect. Now, we don't even have to just talk about weight. We could talk about sexual side effects.
Yeah, because the amount of clients that I will see that is like, especially the men, women as well, but the men that come in that are like kind of twiddling their thumbs, and it takes them session after session after session for them to be like, okay, so like I'm having an issue and I don't know how to talk about it, but me and my wife or me and my partner or me and my whoever, we haven't been intimate. And I was like, oh, okay, well, have you talked to Anne-Marie about it? Like, no, and then it gets so nervous. And I'm like, okay, well, let's talk about this then. Because it's, and that is something that a lot of people won't talk about. So they just will not be compliant with the medication.
What do you think the prevalence rate of sexual side effects is with SSRIs and SNRIs? So that's Prozac, Paxil, Celexa, Luvox, Lexapro, Zoloft, etc.
And everyone?
Yeah, this is men and women together.
30%.
50 to 70.
Oh my God. And they're just like
meta-analysis too. I only meta.
You love you some meta-analyses. That's wild. And they don't. Like I said, it takes. Do you find that people will talk to you about it, or is it so like hush hush, or that?
So I usually bring it up.
Good.
Like actually, you know who the worst offenders are with like myths about medication? Therapists. So when I see therapists, they'll be like, I don't want to go on medication. Yeah. But like meanwhile, they're telling all their clients they need to come be evaluated for medication. Yeah. So I'll be like, all right, talk me through what's going on. They're like, well, I don't want to have sexual side effects. I don't want to gain weight. I don't want to feel like a zombie. I don't want to feel numb. And they just like go through this mantra of like, well, why would I take medication? Because I'm just going to feel X, Y, Z. Probably all the stuff that their clients are telling them that they're feeling. And I always say to them, like, sure, I don't want to feel any of those things either. So like I wouldn't be doing my job if I gave you something and it caused everything you just listed.
Correct.
I mean, sure, you might not be depressed and anxious, but if you're numb, like I'm not going to go home at night and be like, I really helped people today.
100%, right.
Like you're not having a panic attack, but now you're like sitting, staring at Bravo, like doing nothing. Yeah. No, I mean, I'm doing that.
If you're not feeling something when watching Bravo,
right?
Like then, that scares me. Let's fix this.
If Mary from The Real Housewives of Salt Lake City cannot make you smile, I'm not doing my job.
Like, And it is wild how many people have been like, I just don't want to be like a zombie. I don't want my personality to change. I'm like, well, good thing you don't have a personality disorder then. Like, right. Like, and if you feel that, then like go back to Anne-Marie and say this, and this. Like the amount of clients who have thanked me and been like, thank you for having me talk to Anne-Marie. I don't know why I was scared to do that. And I was like, because you have medical trauma from other like people not listening to you, other clinicians not listening to you. It is so rewarding to see that people having that healing process with you, or like I'm like, just trust me when I say like you can talk to her. She's not going to be like, sorry, you just have to live life with a limp dick. You know, like I was like, that's not happening. Like it's so sad to see though people being like, well, you know, I took the medicine and I just feel so like blasé. Okay, well then she's not going to want that. Like maybe in crisis, we have to get you to a place of very neutral or numb so that we can then, but like, we don't want that to be your baseline.
Right. I mean, crisis medication and inpatient medication is a totally different process for me. And anytime I've worked inpatient or collaborated with people inpatient, it's always with the knowledge of like, we're going to do this right now with this being our transition plan into like more permanent, livable situation. You know, like someone's acutely psychotic and I want to keep them out of the hospital. Some olanzapine for a couple weeks is maybe going to do that. Like, and I'll deal with that and then I'll transition it.
Right.
But that's where it's like you have to have a provider that you feel comfortable talking to that's actually going to listen to you. And if like people even need coaching to like talk to me about things, then like I don't even want to know like what they were holding in before.
Yeah, especially because you ask the questions. Like, you know what I mean? Like, you know what to ask. Like, and I'm glad that you said that you actually just are like, are you having sexual side effects? Because these people probably like, sometimes I say some people wouldn't talk wouldn't open their mouth if they're shit in it. You know what I mean? Like they're just like, oh no, I can't talk about that.
Well, with men that I see, I just like out of the gate don't prescribe SSRIs to them, which I mean, any other prescribers can have their own opinions about that. But for me, with an incidence rate that can like push 70%, like why am I going to do that?
Yeah.
So if I know that there are antidepressants that have a much lower sexual side effect profile, I start there anyway. And then if they have them, I deal with it. But for the most part, like any side effects that particular patients are concerned about is going to vary patient to patient, right? Like there are some patients that can afford to gain weight, that probably should gain weight, that need help with nausea and eating and appetite and whatever. So like in those patients, I'm making very different considerations
100%.
than I'm making in another patient who's like trying to stay off of like being insulin dependent from their diabetes type 2, right? Or the patient that's like already having marital issues and issues with libido and whatever, and then sexual side effects may be their primary concern, or the therapists that are worried about all of it.
Right.
You know what I mean? So I think it has to be an open conversation, and these online medication farms are not giving us the space to do that, which I think is actually, although it may look like numbers-wise more people are getting help, my question is, are we actually helping more people?
Are they getting the help that they actually need, right? Because it's like, I think the frustrating and the very tricky thing that you're saying and bringing up with it too is that like it's this machine of like the stigma behind the medication, right? And medication in general. And so we went from one end to the other of like, oh, we're over prescribing stimulants and look at all these, 40 million pills or whatever is how you said from one of the companies, to the opposite side of it of being like, well, don't prescribe it at all now because, people don't need that. It's like you went from stigmatizing it of like, yeah, everyone would just eat it like M&Ms to being like, oh my God, it's so bad, don't do that. And it's like there's a middle ground here, right? And my fear of people like either not being diagnosed properly because those doctors want them, or again being or unmedicated or under-medicated for it. Like that feeds them coming to you and having anxieties of, well, I don't want to feel numb. Well, that's because you shouldn't have been on, an SRI, or you shouldn't have been on this because you actually have ADHD, right? And
Right.
they're treating the symptoms of ADHD that you're experiencing, which is the anxiety and the depression, but you don't have
Right.
anxiety and depression. The amount of people that you've started treating for ADHD, right, that come in, like, I'm super anxious and depressed, and I'm like, okay. And then they're like, but I'm a little concerned because I was just diagnosed with ADHD, and I was like, let's just see what happens with that, right? And or clients that you've taken off of their antidepressant and put them on a stimulant, and they come to me like, oh my God, like my anxiety is gone. It's like, well, I'd be anxious too, I was anxious when I couldn't sit and attend or have a conversation with someone or, emotionally regulate. That would make me depressed,
Right.
So it's
Right.
it's just scary.
Right. Or like, we have people that have ADHD plus panic
Yep.
disorder plus like complex trauma plus OCD, and all of those things warrant clinical attention,
Yep.
but they're all in a lot of ways with medication in direct conflict with each other. So it's really a process of like, okay,
Yeah.
let's try a little of this, and then what's the effect of that? And then like, let's pull back on this. And it really is, it's so much. That's why what makes me laugh when like some of these companies are trying to use AI to diagnose and come up with treatment algorithms, because like with autism, for example, what I always say to my parents of kids with autism is the only thing predictable about how individuals with autism respond to medication is that it's always unpredictable. Always. Like no one will ever convince me that you can reliably say with autism, this is what you see with medication.
Right.
And with complex trauma, it's the same thing.
Yeah.
Complex trauma looks like bipolar disorder. It looks like ADHD. It looks like panic disorder.
Yeah.
It looks like dissociative disorder.
Yeah. It looks like autism, right? Like, I mean,
Right.
100%. That's why it can be difficult to diagnose adults with autism. Like, I think we all know, like, have an issue with like trying to always hold eye contact. Well, that could be a sign of trauma from a parent as a kid and not wanting to look people in the eyes all the time. Like, yeah, it can be,
Or it could be schizophrenia.
100%, right? Like it's, and again, 30 minutes, baby,
Right.
isn't doing that on
No.
No.
No. And even sometimes, like, if you have 2 hours or 3 hours, if you're not asking the right questions, if you don't have the right training, if you don't have the right experience, if you don't have the right, like, level of empathy, like, you're not going to get there anyway. And what we know about the brain is so much less than we know about any other body system. And if you look at any drug that we prescribe in psychiatry, somewhere in the literature you will find like this is a proposed mechanism of action. We actually do not know and cannot say how these drugs actually work.
Yeah.
Which isn't a reason to reject them, right?
Right.
Like we use the clinical knowledge we have and the research that we have and go from there. But that's what makes it more of an art than a science. And if someone wants to make AI into art somehow, like okay, but other than that, like I don't see how we could possibly automate psychiatry so that you can safely, comprehensively, thoroughly see people in the amount of time that these online farms are trying to do.
Well, I hate the word nuance makes me go because it's like so and overused. But like there's too much nuance of each individual person, even when doing surveys, right? I don't think people realize when we get a survey from someone, it's not just like math it out and add it up. It's like, okay, well, why do they answer? It's weird because this survey kind of conflicts with this survey. So let's look at the way this question was worded, so that you know what I mean. Like that in itself, like if you just input that, it's not giving you the nuance of the person. Like, hey, why did you answer it this way, or did you answer it even honestly, or whatever?
Right.
So when it's spitting something out, or it's just like a one size fits all, but it's AI, that again gets super dangerous.
Right. I always send people, there's probably like a list of maybe like 10 to 15 assessments I send before an evaluation. But like I have my process of how I look at them. So like someone with ADHD is always going to have a lot of yeses on their mood disorder questionnaire. It's just like the reality of how the questions are played out and the symptoms. But someone with complex trauma is also going to have a ton of X's on the mood disorder questionnaire. But there are like specific questions on each of these assessments that I use that I look at because a lot of times with different co-occurring diagnoses, those are the questions that they'll answer no to. And so you have to be able to look at these assessments like with your actual human brain and compare them to each other and then ask follow-up questions that an AI could not ask.
Yeah.
And it's just, at the end of the day, psychiatry, I think, is not something that can ever be replaced by AI or robots or should. I mean, I think we're trying to.
Right.
But
well, and just things too of things that the clinician knows, right? So like I was like, I really kind of am toying with the idea. One, I have to take my licensure exams, and that has been an absolute bitch to try to do. I took a practice one. You have to have 70% to pass. It's 150 questions, but they will randomly just take 30 questions away after you take the exam. So maybe you got all 30 of those right, though, and so you actually did really well, but it doesn't matter because they don't tell you which 30. It's just at random. I got 71, and that was skin of teeth. And I looked at the ones I got wrong, and those are the ones I felt super confident about. So I was like, and then I was toying with the idea of like maybe going to school again. So I'm like,
For what?
just getting a PhD. I don't know. Then I could be teaching on the side as well. I don't know, but I was just like toying with this. So I was like, I want to go get my what's it called, the learning disability stuff checked. So I went to a psychiatrist that did the 2.5 hour let's see what learning disability stuff this. And he's like, as he's doing it, he's like, we check for these things. I'm like, I already was diagnosed with this and this, and and I take medication for ADHD and diagnosed with all that. He's going through it, and he's like, okay, well, this will give. He's like, with the ADHD, it's fine, but this will give all the learning stuff. And so he was like, I'm seeing autism. I'm like, well, that's been diagnosed, but yeah. He's like, okay, well, I'll put it in there. But one of the things that made him gasp, he was like, he's like, what medication are you taking? Right, this, and then whatever the beta blocker, the nimra, I don't even know what the name is. And he goes, for why? I said, well, POTS and this, and he goes. So when he goes, I'm seeing that a lot of people with autism also, there's this thing with POTS as well. Mm-hmm. And that is something that an AI thing wouldn't just, and so it was something that even reaffirmed even more. And I was like, baby, I've been diagnosed with some of this stuff already. But he was like, well, I'll throw it in this so that you have it too. But it was so interesting to see that moment of again, an art mm-hmm. of this. And obviously there's science behind it, but that moment also, he goes at the beginning of it, was like, okay, so what are your interests? You have hobbies, and stuff like that. So I said, oh, I do theater, and I guess I like running and the gym. Yeah. He's like, and anything else? I said, no. He's like, okay. So we get to the end. He's like, I think that we're gonna potentially a nonverbal learning disability and aphasia. I told you I already had that. So it's like, okay, cool. And then he goes, definitely still, the autism is it's weird because you don't have a special interest. And I said, what do you mean? He goes, well, I asked about hobbies or interests. I said, we asked about hobbies. Hobbies and special interests are two different things. He's like, what do you mean? I said, well, hobbies you do. You can do a hobby, but special interest is this. So I started just rattling off all these things about my obsession with deathly diseases and Batman and all this. And he was like, okay. And I was like, what? He's like, I just realized that, yeah, you took that very literal. Baby, isn't that why we're here at the end of the day?
Yeah. But you brought up a great point with the POTS thing, too, that I did want to mention, that there are so many physical health illnesses that can also have psychiatric side effects. Yeah. So to ensure that you're seeing providers that are looking at that, I just told you the other day, I said to a client, I can't diagnose you until we check out this, and this, because I don't know whether these symptoms are related to this thyroid problem or narcolepsy or sleep apnea or POTS or and I think that that's super important too, because say even with POTS, which is postural orthostatic tachycardia syndrome, which is becoming, luckily, a little bit more well-known lately. But the brain fog associated with POTS is so huge. And sometimes people can be gaslit for, years into, you're just so depressed. But you might not be. Or you might be depressed because you're so tired and foggy all the time.
Right. Or every time you stand up, you see spots. And
right.
Did we ever tell people about – so I in Marie and I knew each other for years at this point, and I was telling her, I was like, so I did this party trick where like if I stand up too fast, I had no idea what the fuck POTS was. And you even said at one point, you're like, I think I'm gonna do like a POTS like support group, or I see a client with POTS and they're very, very depressed and stuff like that, or they're like we talk about it, it's pretty traumatic, and I was like, I don't know what POTS is. And I was telling about how it's like a perch. I was like, actually, one time with my ex, like it was like 12 years ago, I stood up and we used to dead weight, and I passed out because I stood up too fast. And you're like, the fuck, tell? And I was like, yeah, like that just sometimes happens to me. And then I think it was like the Apple Watch we did, and I like stood up and it went thoop and shut up, and I was like, oh, that's not a real thing. Like this is something that just doesn't happen because it's silly.
Right.
This is a condition.
Right. Well, I didn't even know what POTS was probably like maybe 10 or 11 years ago, and I I did have a dysrhythmia, a congenital dysrhythmia, and so, but when they finally found what the dysrhythmia was, they also diagnosed me with POTS at the same time. But the funny thing was, probably like a year before that, I had a client who came to me with this POTS thing that I didn't know what it was. This was probably like 2013 or something. And I was like, okay, whatever. And then I get diagnosed with POTS, and I was like, oh, shit. I probably should have validated that girl a little more.
Yeah.
And so I've been hyper aware of it since then. But the interesting thing is since COVID, they've found a lot of people have gotten this sort of like post-COVID POTS. Well, maybe we should explain what POTS is.
Yeah.
POTS is considered dysautonomia. So it's a dysregulation of your autonomic nervous system. So it's not necessarily like a heart problem.
Mm-hmm.
It's a problem with how the body regulates your heart rate. So postural means like when you switch positions. So when you go from like laying to sitting or sitting to standing, your heart rate goes up. And one of the telltale signs of POTS is that it's your heart rate and not your blood pressure.
Correct.
So you don't have that, what we call postural hypotension, where when you stand up, you feel lightheaded because your blood pressure drops. When you stand up, you a lot of times feel lightheaded because your heart rate goes up by like 40 beats per minute higher than normal.
Yeah.
But there's a lot of other symptoms associated with it, namely like brain fog, fatigue, GI stuff, circulation stuff.
The GI stuff.
Basically all the symptoms that you had that you told me were other things.
I'm like, I'm pretty sure it's just
I
this.
convinced you it
IBS.
was
Yeah.
not.
I'm like, all hot girls have tummy issues. Like, girl, it's wild. And then being on a beta blocker to help with that, I remember being like, I'm gonna be 34 in like, 2 weeks. I would say for like 25 years at least, I've noticed like it was the first time I was able to stand up without being like, I'm gonna fall back or pass out, which I have. Like the weirdest, strangest feeling in the world of standing up and then being like, oh, can't see anymore. I'm going to sit back down. It's well, I say sit back down. I don't have the option. My body just flops.
Yeah. A lot of times with POTS, I'll ask people because I have this thing where like I feel like I can't take a deep breath. It like feels like I have to breathe above this like shelf. Yeah. And I always tell people about that, and they're like, "Oh my God, I have that too." Well, people with POTS, not everyone. But it's like this distinct thing that's like hard to describe. And then when I describe it to people with POTS, they're like, oh my God, yeah. So I think it all goes back to the importance of like having conversations and being able to trust the person you're going to for care, whether it's your primary care doctor, a specialist, psychiatrist, psychiatric nurse practitioner.
Yeah.
If you feel like you're not being heard.
Yeah.
You need to find someone who will hear you. But mostly, I think like my takeaway from all of this is that like you don't have to compromise any aspect of your well-being for something else. Like
Correct.
There are so many medications and so many treatments in psychiatry that you can work on having a balance.
Absolutely.
Where you're not like, well, in order to be mentally well, I have to deal with A, B, C, D. And there were so many people in your comments that said that I was like reading them like so upset. Like, I can't believe that people think that this is the way they have to live.
It is so seldom that the answer will be like, I'm so sorry. Like we do have kind of like a fork in the road moment. It's, and even then, it's not that like, and you just got to deal with it, right? Like that is when you can utilize a nutritionist or a therapist or, like It's why sometimes it's good to have the both, right? Sometimes medication can take you all the way there and it's great. Sometimes therapy can take you all the way there and it's great. But sometimes a holistic approach is even better. But very seldom we have, I think, in true form, like, yeah, sorry, you're Sophie's choice. You got to choose, babes. It's either this or this, right? Like,
no, I mean, that will never be something I will say to a patient. A patient might say to me, like, I want to take a breath and, like, I'll deal with this A, B, C, D for now because I, like, need a break, which is fine. I'll always go the direction my patient wants to go. But regardless, if my patient's like, I'm not comfortable with X, Y, Z, we'll talk about the risks of making changes, but at the end of the day, I'm going to make changes because it's my responsibility to make my patients feel better, not like my definition of better.
Right. And like you had said before, and I've seen something that I've done, if they ultimately, I'm like, I don't want to take this, I don't like the side effect, and they're not listening to me, so I'm not going to take the med. That happens so often.
Oh my God.
Like,
so often.
Yeah. And it's like, well, I haven't taken it in 3 months because the amount of clients, well, I'm nervous to take this med because of the sexual side effects. Who do you see? My PCP. Okay, well, I'm gonna tell you to refer you to Anne Marie then because like you need to see someone else. If you're not being heard in that way, we're not doing that. Like people deserve and are worthy of feeling better, and you're worthy and deserving of having someone to listen to you.
Absolutely. Absolutely. And no matter what the side effect is, I've had patients that have told me that after they took a med, they had this like weird itch on their nose and then they would like sneeze 5 times and like they kept telling me about it. And I was like, you know what? This is a really distinct thing. Like I'm going to go back to the drug company and be like, have you heard this? Sure as shit they had.
Oh my God.
Yeah.
They're probably like, how do you just like list that side effect?
Yeah.
May cause 5 itches and 2 sneezes.
Yeah.
Like, yeah.
And ever since the nose, sneeze, itch thing, I was like, I have to validate like everything.
Yeah.
You know, and
So
obviously there's a somatic patient, but that's again why AI can never replace us because you have to know how to balance that like med anxiety with like making sure your patients feel heard and validated.
Absolutely.
Or the therapist that you work with.
That's true. This is all to say, it is okay to shop around for a provider or a therapist that listens to you. And I say treat it like dating, right? Like get to know them. If you're not jiving together, like I always say, I don't have any ego when it comes to being a therapist. Like it's no like skin off my nose. I will sit down and help you find a therapist that works better for you. If I didn't validate you enough, like you baby, you got to find what works for you or you're not going to get better.
No.
Right?
Nope, not at all.
Oh, look at us. We're amazing.
I know, right?
All right. Let us know what you'd like to hear from us, what you thought of the episode. Feel free, if you feel comfortable enough, tell us about your med journey or med stories. But we will see you next week for another fun, silly episode.
This was so fun and silly.
Well, some of it was silly. Some of it was fun. Some of it was, I learned a shit ton from it, so that's good.
That's good.
We have some things
down
up
with
our
the med
sleeves.
farms.
Yeah.
ADHD farms, med farms,
any farm that's not like providing
alpacas or soybeans or
100%. If you're not getting food or it's not one that you can pet animals ethically, then
or make yarn from.
Yeah, you can make yarn
from alpacas.
Oh, I knew that. I was joking. Alpaca yarn. Yeah. So down with the farms and up with us.
Yeah.
All right.
Good.
Bye.